Welcome back to the Liberty Perspective. I'm Joe Marshall. Today I got a show on oxygen toxicity and how it relates to the centralized no treatment protocol that came down through COVID, right? Well, that may have played a bigger role in the rise in excess deaths that are being attributed to COVID in a number of different ways, right? Well, the last show that I did on the population pyramid of baby boom bump versus COVID excess deaths, right? That kind of showed a scenario in which the evidence points to a number of potential nefarities that are happening, right? Well, the whole look into the oxygen toxicity kind of does the same thing. And I got some information I'm just going to go down through here with you. I'll get right to it because I don't want this show to be any longer than it has to for you. The first thing that I just wanted to ask and put out there for, to take into consideration for all of us is, can breathing too much oxygen actually cause oxygen toxicity? Is it a thing? You know what I mean? So I just kind of go back to the beginning because, I'm just a landscaper, right? And landscape and ex-hack, right? Corrections officer, right? But anyways, I got this test here that I kind of went over. It's can breathing too much oxygen actually cause oxygen toxicity? And the takeaways on this is this study right here, our article. And it says key takeaways. Air contains about 21% oxygen. Breathing in higher oxygen concentrations can cause oxygen toxicity. 21% oxygen is the normal. That's how much percent oxygen is in our normal atmosphere that we're breathing all the time. It's 21%, they say. But the oxygen toxicity can affect all body organs. It can affect all body organs, but most often causes damage to the lungs, eyes, and brain. Most people recover from oxygen toxicity, but it's still a good idea to avoid high oxygen concentrations when possible. It's not possible to get oxygen toxicity from breathing regular air. So we know that if they're just the regular air, no matter how we hyperventilate, whatever, you can't get oxygen poisoning from breathing atmospheric air. So that's because no matter how fast or hard you breathe, the concentration of oxygen in the air is always the same. Well, it probably changes by elevation, right? Which is about 21%. But in medical settings, people can receive a wide range of oxygen concentrations from 21% to 100%. Because they're actually trying to deliver 100% oxygen in some instances to your lungs. Do they know? I'm not gonna say we but do we as Americans, do we as the humans know what that 100% oxygen is doing to our lungs? Are they just kind of winging it? That's a question that needs to be asked. Bottom line, too much oxygen toxicity can lead to oxygen toxicity. People can develop oxygen toxicity when they breathe in high concentrations of oxygen. This usually happens in medical settings. When oxygen is used to treat certain medical conditions, it can also happen if someone is receiving hyperbaric oxygen therapy, but it's possible to avoid oxygen toxicity by using the lowest effective oxygen concentration. Why does breathing pure oxygen kill you? So just a little foundation, right? Breathing oxygen at pressures of 0.5 bar or more, roughly 2.5 times normal. So 0.5 bar, whatever that is 2.5 times our normal feed. For more than 16 hours can lead to irreversible lung damage and eventual death. So breathing oxygen at pressures roughly 2.5 times normal for more than 16 hours can lead to irreversible lung damage and eventual death. So we're not barking up the wrong tree with even the possibility of this, right? So it is possible, and it can happen, and has, right? Let's go to the Cleveland Clinic, see what they got to say. They say too much oxygen can lead to oxygen toxicity or oxygen poisoning from the Cleveland Clinic, right? A little primary vocab prep for what we're going to see, because you're going to see things in here. I'm going to have to read over them for you. And, I'm not an academic in any way whatsoever. But I can look up things in the dictionary or online to get the meaning of things. And they got this PaO2, which test measures partial pressure of oxygen, or the oxygen pressure in arterial blood. So it's the oxygen in your blood. It relates to the oxygen in your, reflects how well oxygen is able to move from the lungs to the blood. So it's going from when you breathe it in, the oxygen going into your blood. That PaO2. And the FiO2, which is the percentage of concentration of oxygen that a person inhales. So it's the oxygen that you're breathing into your lungs, and the PaO2 is the oxygen that, once it's in your lungs, is going to your blood. And they say, so it's the percentage or concentration of the oxygen that a person inhales. When we can never actually know, they say, what the FiO2 of the patients is unless we accurately know what their peak inspiratory flow is, or we are delivering high flow oxygen at a rate that is estimated to be greater than the air peak respiratory flow. The quick reference charts that we sometimes see equating an oxygen flow rate to a FiO2 is assuming a peak inspiratory flow rate of 20 to 30 liters per minute, but it's merely an approximation. So an oxygen flow, the quick reference charts that we sometimes see equating an oxygen flow rate of a FiO2 is assuming a peak inspiratory flow rate of 20 to 30 liters per minute. The breathe-in rate. For more on high flow and 100% FiO2. Okay, you got these things that were just a little bit of a background, because when you're looking up oxygen, when you're looking up oxygen toxicity, you come across these terms, this terminology in almost all the studies that you're going to be reading. The U versus the atmosphere, 100% FiO2. The FiO2 is the fraction of inspired oxygen. So you're looking at fraction of inspired oxygen, FiO2. Let's break it down. A fraction is part of the whole. Inspired means we're breathing it in. So it's just the fraction of oxygen in the air that you're bringing in. Normal's 21, right? Because the atmosphere is 21% oxygen. And then they got that the fraction of inspiration oxygen is 21%. That's normal atmosphere, right? So if you had an FiO2 of 50% or 0.5, it would be 50% oxygen, which is twice as much as normal. And then FiO2, or fraction of inspired oxygen, is 100%. You're not even breathing in atmosphere anymore. They're pushing it into your lungs. There's no other way to get it in there, right? So fraction of inspired oxygen ratings are approximate and will fall with increasing inspiratory rate, how much we actually are breathing in. So different people are going to breathe in different amounts. You can reference charts like this to get a general idea of oxygen percentage delivered, but we have to keep in mind that the patient is sucking air like a Kirby. Keep in mind that the patient that's sucking air like a Kirby is going to suck a bunch of room air and dilute that. But that's what I was getting at. So, but the fact is that when I read down through these things, you're going to see this, the gist is that this is the air. PA2 is the oxygen, the air in your lungs with the oxygen getting to the blood. The fraction of inspired oxygen is how much oxygen is in the air that you're actually breathing into your lungs. It just helps clarify some of what we're going to be reading is all. Oxygen toxicity in critically ill adults. This is from February 2021 in this article right here. Just start digging in, right? See what we come up with. Oxygen supplementation is one of the most common interventions in critically ill patients. Despite over a century of data suggesting both beneficial and detrimental effects of supplemental oxygen, optimal arterial oxygenation targets in adult patients remains unclear. So, it's not a settled science. It's not a settled science like, climate change and, vaccines, right? Just saying. But the point is that it's unclear after a century of data suggesting both beneficial and detrimental effects of supplemental oxygen, optimal arterial oxygenation targets in adult patients remain unclear. I just wanted Human autopsy studies from the 1960s purported to provide histological evidence of pulmonary oxygen toxicity in the form of diffuse alveolar, the alveoli damage. The alveoli in your lungs that actually transfer the air and oxygen in your lungs to your blood, right? But, yeah. So, autopsies from the 60s provide the evidence of pulmonary oxygen toxicity in the form of diffuse lung damage, alveoli damage. However, concomitant ventilator-induced lung injury and or cause of acute lung injury may explain these findings. Ventilator-induced lung injury and or other causes of acute lung injury may explain these findings. Okay? Just putting this out there. Next study, targeting normoxemia in acute respiratory distress syndrome may cause worse short-term outcomes because of oxygen toxicity. And this is this study here. This is from 2014, This is just for your consideration. Because it's just kind of stuff that I put through that kind of pertains, and it might not make any sense now, but it's a baseline of knowledge coming into what, the whole subject matter of oxygen toxicity, right? The primary goal of this perspective is to provide evidence that in targeting normoxemia, patients may be exposed to unnecessarily high fraction of inspired oxygen levels that exacerbate lung injury. In support of this idea, we highlight the uncertainty in our understanding of human oxygen toxicity as evidence suggests that oxygen can be toxic to the lungs of normal human beings even at moderate concentrations of inspired oxygen of 50 to 60%, right? 0.5 to 0.6. Furthermore, experimental models demonstrate that coexisting lung inflammation such as sepsis increase susceptibility to oxygen toxicity. When I saw that, I said, geez, sepsis. Experimental models demonstrate that coexisting lung inflammation such as sepsis increases susceptibility to oxygen toxicity. And this was back in 2014, right? It's only 5 years before COVID hit, right? 5 or 6 years. But what I'm saying is that threw a question in my brain. Sepsis. I have heard nobody talk about sepsis, and I did a little bit of a deep dive into the correlation here. And we'll just keep reading on this. Work also suggests that hyperoxia can lead to worse outcomes in other acute conditions, including cardiac arrest and chronic obstructive pulmonary disease, COPD, exacerbation. Okay? A safe level and duration of oxygen exposure has not been established even in normal human beings. As of 2014, a safe level of duration of oxygen exposure has not been established even in normal human beings. All right. More recently, you see, this Griffin and colleagues demonstrated increased lung inflammation and impaired endothelial and epithelial barrier function compared with room and air exposure. They demonstrated increased lung inflammation and impaired endothelial and epithelial barrier function compared with room air exposure. We still do not know the minimal concentration of oxygen and duration of exposure sufficient to induce lung damage in normal human beings, let alone compromised human beings that may have other things going on, right? What's normal? Evidence suggests that many patients with acute respiratory failure are exposed to excess oxygen. Evidence suggests that many patients with acute respiratory failure are exposed to excess oxygen, period. In the ARDS network, a frequent violation of the ventilator's management protocols was a lack of response to that PaO2 oxygen above the goal range. So they set a goal. They want so much oxygen coming from your lungs into your blood. They want to maintain a certain level. But what they're saying is that a frequent violation of the ventilator management protocols was a lack of response to the that level of oxygen going from your lungs to your blood above the goal range. Okay, providers, notice they're not doctors anymore. They're not doctors. They're healthcare providers. They're not doctors. They're just a conduit. Just a conduit now through which the centralized medicine flows. You don't want that centralized medicine to flow through you, they just cut you out. They're not doctors anymore, they're providers. Usually respond quickly when that oxygen level going from your lungs into your blood or oxyhemoglobin saturation falls below the goal range. They respond quickly. Providers respond quickly when the levels are low, but they are slow to respond when arterial oxygenation exceeds the goal range. This appears to be related to clinician behavior and may also be based in a lack of understanding of oxygen toxicity in humans. Well, it's not like we're throwing the idea of the possibility out the window here, are we? You know? Suzuki and colleagues assessed physician responses to oxyhemoglobin saturations greater than or equal to 99% in patients with acute respiratory failure. This study strongly suggests that physicians accept the fraction of inspired oxygen levels less than 60% as safe even in patients with acute respiratory failure. The study suggests that physicians accept inspired oxygen levels less than 60% as safe, and even in patients with acute respiratory failure. Even after ICU adopted a conservative oxygen therapy approach to avoid unnecessary exposure to oxygen nearly half of the levels that were above the upper limit of the goal range. Despite significant non-adherence, 2/3 less oxygen was used in the conservative group without adverse effects. Thus, many patients are exposed to inspired oxygen levels that are higher than necessary to achieve a goal arterial oxygenation rate. Physicians may miss opportunities to avoid unnecessary oxygen inspired oxygen levels because they frequently rely on a pulse oximetry to monitor arterial oxygenation. Physicians may miss opportunities to avoid unnecessary exposure to high levels because they frequently rely on pulse oximeter to monitor arterial oxygen. So they're saying that's one of the reasons why they're missing the opportunity, are these pulse ox things. That's the study. You want to dive into it right there. And you want to dive into it for some more. Targeting noxemia, normoxemia, and acute respiratory distress syndrome may cause worse short-term outcomes because of oxygen toxicity. They've known about it since 2014. Well, that was 2014, right? But sepsis? Sepsis just gets thrown into the mixture all of a sudden. Sepsis associated with COVID-19 infection is more common than thought. I was like, you know what, sepsis? I wonder. They're saying sepsis can cause more lung damage with high oxygen levels under other conditions, and sepsis is one of them. So what's the relationship between sepsis and COVID, right? It gets interesting. This is from September 23. Today, in JAMA Network, open researchers provide new evidence that the prevalence of SARS-CoV-2 associated sepsis among hospitalized adults is higher than previously thought. There it is. There it is. But deaths from the condition became less frequent as the pandemic progressed. Well, the no treatment protocols were strictly enforced at the beginning of the pandemic. Strictly enforced. If you got diagnosed with COVID, you were sent home. You were sent home. Well, if you get too sick to do anything, come in, right? Because there's nothing we can do for you. The no treatment protocol. Dr. McCulloch has testified to the fact that 95% of all COVID associated or COVID cause, quote unquote, right, hospitalizations of deaths could have been prevented with early treatment, but that they didn't allow. That they didn't allow the centralized protocol, refused to treat these people. So no matter what you had, you were sent home. And if you had a positive test, you could have had anything. You could have had pneumonia, you could have had the flu, you could have had whatever. You could have had any one of a number of things going on, including sepsis. That's what I'm getting at, And you were getting no treatment for it. If you tested positive for COVID, you weren't allowed treatment for it. Right? Because these tests, especially at the beginning, were testing for only COVID. Yeah. A total of 23,276 patients, 5.4% of them were hospitalized for SARS-CoV-2. 5.4 were hospitalized for SARS-CoV-2. 1.5% of them had SARS-CoV-2 associated sepsis. And 7.1% had presumed bacterial sepsis without SARS-CoV-2 infection. So the biggest cohort on this right here, a 7.1, had presumed bacterial sepsis, presumed, big word, sepsis without COVID-2 infection. Yeah. 5.4% of these people were hospitalized. So the study is based on records of adults admitted to one of 5 Massachusetts hospitals from March 2020 to 2022. A total of 431,017 hospital encounters from 261,595 individuals were included in the study. 5.4% of them were hospitalized for SARS-CoV-2. 1.5% of them has SARS-CoV-2 associated sepsis. and basically six to seven times that many had bacterial sepsis, presumed bacterial sepsis. Right? I mean, you don't treat viral sepsis with antibiotics. Well, that's not necessarily true either, right? But we're going to get into that. SARS-CoV-2 associated sepsis was defined as a positive. SARS-CoV-2 associated sepsis was defined as a positive SARS-CoV test, SARS-CoV-2 test, PCR, and concurrent organ dysfunction. The most common organ dysfunction for SARS-CoV-2 associated sepsis were respiratory distress and failure requiring more than a nasal cannula, seen in 82.2% of patients. The most common organ dysfunctions for SARS-CoV-2 associated sepsis were respiratory distress and failure requiring more than a nasal cannula, seen in 82.2%. Mortality for COVID-related sepsis dropped. Crude in-hospital mortality for SARS-CoV-2 associated sepsis was 22.3% overall. Crude in-hospital mortality for SARS-CoV-2 associated sepsis was 22.3% overall. Crude mortality for presumed bacterial sepsis was half of that, at 14, well, more than half, was 14.5%. Crude yeah. So 23% of this mortality they said was SARS-CoV-2 associated sepsis. Now that doesn't mean SARS-CoV-2 caused, it's just associated. So you could have a bacterial infection at the same time as being tested positive for SARS-CoV-2, right? So is it associated? Is it, SARS-CoV-2 caused? What are they saying here? I don't know. But what I'm getting out of it is that 22% of these freaking people that died from SARS-CoV-2 in this study, the crude in-hospital mortality for SARS-CoV-2 associated sepsis was 22.3% overall and 14.5% for the presumed bacterial. The incidence of SARS-CoV-2 associated sepsis fluctuated in tandem with changes in local community incidences. The 14.5% remained consistent across the study period, but the crude mortality rate due to SARS-CoV-2 associated sepsis dropped from 33% in the beginning in the first quarter of the study to 14.9%. They had as high as 33% of these crude mortality for SARS-CoV-2 associated sepsis. Right? Overall, SARS-CoV-2 associated sepsis was present in 28.2% of patients admitted with SARS-CoV-2. So if they had sepsis, they had SARS-CoV-2 associated sepsis, which means they don't know if it's caused or not caused. It's a viral or a bacteria yet, but it's associated. Overall, SARS-CoV-2 associated sepsis was present in 28.2% of patients admitted with SARS-CoV-2. So the no treatment protocol, these people are home getting no treatment, and they're coming in with sepsis because of the no treatment. Whether that sepsis was caused by SARS-CoV-2 virus or any virus or a bacterial infection that they had but weren't getting treated for because they tested positive for COVID. Another casualty of the no treatment COVID protocol, right? The incidence of SARS-CoV-2 associated sepsis fluctuated in tandem with the changes in local community incidences, but tended toward fewer causes between the pandemic onset and November 2022. The authors said, in-hospital mortality rates were initially high for SARS-CoV-2 associated sepsis at 33.4%, but decreased to 14.9% by November of 2022. Where they had didn't they have tests that were testing for more than just COVID at that time, right? The panels were testing for more than just COVID. So you could be diagnosed with a couple different things that maybe you could have gotten the treatment for, I guess. I don't know. I'm just throwing it out there for your consideration. See, also, SARS-CoV-2 caused more deadlier cases in sepsis than thought. Okay. This is from 2023. This October of 2023. This article is September 2023. This article is October 2023. New research suggests that virus responsible for COVID-19 was a more common and deadly cause of sepsis early in the pandemic than previously assumed. So they're saying that COVID-19 virus was a more common and deadly cause of sepsis early in the pandemic than previously assumed. Well, why wouldn't they want to say that? If they say that the virus caused it, then they have plausible deniability on the fact that the no treatment protocol, these people were getting bacterial sepsis from some other thing or from whatever. Right? Accounting for about 1 in 6 cases of sepsis from March 2020 to 2022. So 1 in 6 cases of sepsis was accounted from this, they're saying, were caused by COVID. To capture a fuller, more accurate picture of the viral sepsis cases, investigators from Harvard Medical University analyzed electronic health records. They got the electronic health records into the mix now too, right? Yeah. They knew from their previous work that these electronic health records could provide more accurate estimates of sepsis incidents and outcomes than administrative data sets. The new study marks the first time researchers have used the methods to study viral sepsis. COVID and sepsis by the numbers. The team quantified the incidences of mortality for SARS-CoV-2 associated sepsis using clinical criteria adapted for U.S. Centers and Disease Control and Prevention, which incorporated positive SARS-CoV-2 tests and clinical signs of organ dysfunction. Using electronic health records data from the first 2.5 years of the pandemic. The team identified 431,017 hospitalizations from 261,595 individuals. During that time, 5.4% of hospitalizations were due to SARS-CoV-2 infection. No. 5.4% of the hospitalizations were. Wouldn't that a pandemic that was flooding our hospitals with all these COVID cases be more than 5.4%? Wouldn't it take more than 5.4% of the population to do that being tested? During the time, 5.4% of hospitalizations were due to SARS-CoV-2 infections. I'm just throwing that out there. Of course, those 28.2% had SARS-CoV-2 associated sepsis. Of course. Of those, 28.2% had SARS-CoV-2 associated sepsis. So 28.2% of the SARS-CoV-2 that came into the hospital had sepsis. 28% of those people that came into the hospital with COVID had sepsis. 28%. So you've got 28% of the people that are there. I don't know. If they're home on the no treatment protocol, what's that say? What's that add up to, you know? The mortality rate for patients with SARS-CoV-2 associated sepsis was initially high, 33% over the first 3 months of the pandemic. %28 of the people that come in for COVID had sepsis. 33% of those died. However, the rate declined over time and eventually became similar to the mortality rate for presumed bacterial sepsis, about 14.5%. Because they were getting treated, maybe, right? Maybe it dropped in half because maybe those guys were getting treated. The rate then remained stable through the study period. The study's design and use of electronic data provides a framework for future research. There it is. Predicting severity of COVID-19 disease using sepsis blood gene expression signatures. This from January 2023. This study right here. Predicting severity in COVID-19 disease using sepsis blood gene expression signatures. Abstract. Severely afflicted COVID-19 patients can exhibit disease manifestations representative of sepsis, including acute respiratory distress syndrome and multiple organ failure. The expression of sepsis gene expression signatures in severely afflicted COVID-19 patients indicates that these patients should be classified as having severe COVID. Accordingly, in severe COVID-19 patients, these signatures should be strongly considered for the mechanistic characterization, diagnosis, and guidance of treatment using repurposed drugs. The thing is that sepsis is deadly, and it needs to be treated ASAP, right? Meanwhile, you've got how many people at home that have been tested positive for COVID that they're not getting any treatment? Just putting it out there. Just a question. In the ongoing COVID-19 pandemic 2020 to 2022, it is increasingly evident that many of the millions of individuals who die with severe disease succumb due to sepsis. I haven't heard anybody talk about sepsis. I haven't heard the word brought up. When I saw this and I started digging into it, all the stuff that I read and all the people that I listen to all the time, and I'm constantly listening to it. My wife yells at me all the time, COVID, COVID, COVID. It's all you ever listen to. Not really, but seems like it sometimes. I never heard sepsis even being brought into the conversation. This is why I'm doing this, you know. Maybe I'm the only one in the dark on this. I don't know. Yeah. In the ongoing COVID-19 pandemic, it is increasingly evident that many of the millions of individuals who die with severe disease succumb due to sepsis, a life-threatening dysfunctional response to infection. Studies show that many or most individuals who die from severe COVID-19 infections had an acute respiratory distress syndrome, ARDS. And high sequential organ failure. Jeez, wonder what those two symptoms are related to, right? Furthermore, extensive phenotyping studies have suggested that features of sepsis, such as considerable organ damage, an example, lung and kidney injuries, and long-term depressed mental health and immune responses are prevalent in severe COVID-19 patients. So you've got the sepsis symptoms prevalent, not present, prevalent in SARS-CoV-2 patients. What's the chances that these SARS-CoV-2 patients are just sepsis patients that they weren't treating? that their fraudulent fraudulent PCR test said was positive for COVID, which made it so they couldn't be treated. Just throwing it out there. The possibility has been discussed that this viral-driven sepsis, but the involvement of bacterial infections in at least 50% of the severely afflicted COVID-19 patients has also been established. So they're saying here the possibility has been discussed that this is a viral-driven sepsis. The involvement of bacterial infections in at least 50%. And at least 50% of the severely affected COVID-19 patients has also been established in a white paper that came out a month after a study where they were basically saying it was viral, right? Yes. That's key. That's key. Okay, from the University of Pittsburgh. What is the treatment of sepsis? What is the treatment? We got to get into what is the treatment, right? I'll be right back. I'm back. Sorry about that. I had to take care of a couple things. Yeah, just to go back. Yeah, studies have shown that most individuals who died from severe COVID-19 infections had an acute respiratory distress syndrome, ARDS. We'll get a little bit more into that ARDS too here in a minute, I think. From the University of Pittsburgh. What is the treatment? What is the treatment for sepsis, right? And how does that no treatment protocol for COVID play into it? Treating sepsis caused by a virus. If the infection came from a virus or other germ, doctors will only give you antiviral drugs and can fight that germ. Antibiotics don't help viral infections. That's the standby narrative. That's the standby narrative. Well, it's a virus, and antibiotics ain't going to help you with a virus, right? Does that mean, per the centralized no treatment protocol, that those who had a bacterial sepsis but also had tested positive for COVID did not get the much needed antibiotics ASAP? That had that study that came out. Well, they had this study that came out that they're viral COVID caused sepsis more than we thought. But it's been established that at least half of the COVID people that tested positive came with COVID had bacterial sepsis, right? At least. Does that mean that per the centralized no treatment protocol that those who had a bacterial sepsis but also had a tested positive for COVID did not get the much needed antibiotics ASAP, which has been established as per above was indeed the case in at least 50% of the COVID patients? How might that denial, or at best a delay in treatment of that sepsis, affect the health and mortality of those COVID patients? Those COVID patients, right? Right? More on the treatment of what the treatment of sepsis is from the Sepsis Alliance. Sepsis is a medical emergency. It needs to be treated as such. In other words, sepsis should be treated as quickly and efficiently as possible as soon as it has been identified. When you were tested positive for COVID, that it didn't let you, didn't consider the possibilities, and it didn't allow you to be identified with anything. You had COVID. Treatment includes rapid administration of antibiotics and fluids. So it's just antibiotics. It's antibiotics. Right? The risk of death from sepsis increases by an average of up to 7.6% with every hour that passes before treatment begins. How many people were at home getting sicker and sicker for not just hours but days before they were finally brought into the hospital and treated? Or, with a centralized protocol that probably that may or may not have even accounted for other possibilities besides COVID, at least for a while, right? Patients with severe sepsis or septic shock who are treated in an intensive care unit can experience issues related to the illness and medications, the lack of sleep, and overstimulation of having people and noise around them 24 hours a day. This can result in agitation, confusion, and even hallucinations. The treatment, looking for information about the treatment bundle used in most hospitals known as the SEP1. I got the SEP1 thing. I didn't dig into it much because it's not the treatment itself that I wasn't interested of. I just wanted to know, to dig into. I just wanted to know get a broad idea of what the treatment for sepsis was, and to see if it had anything to do with how it played off of the no treatment protocol for COVID. All right? But I wanted to throw that SEP1 out there just so that it's acknowledged. Antibiotics treatment. Physicians prescribe antibiotics. Physicians prescribe antibiotics, usually more than one type, based on the type of infection. Blood spectrum antibiotics are the first line of medications. Blood spectrum antibiotics are the first line of medications. These are antibiotics work against several of the more common bacteria. These are intravenous antibiotics so that they can get to the blood system quickly and effectively. You need intravenous, man. You need intravenous intervention of antibiotics when you get sepsis. Antibiotics alone won't treat sepsis. You also need fluids. So it's not just you need more than just antibiotics. You need fluids, IVs. Sepsis and septic shock, current treatment strategies and new approaches. They knew this in 2017. The last one was from, I don't know, I didn't get a date on that. Sepsis and septic shock, current treatment strategies and new approaches. That's this study here, or white paper. In recent years, studies have been published that describe the treatment of sepsis patients. Most of these approaches aim to moderate or interrupt the sepsis physiopathology and prevent multiple organ failure. Clinic features. The occurrence of clinical findings can occur in the form of fever. The occurrence of clinical findings, the clinical features of sepsis, okay? The occurrence of clinical findings of sepsis here, right, can occur in the form of fever, mental fog, thrombocytopenia. It's a low count of blood platelets. But I looked it up. Fever, COVID-19 fevers. These are sepsis symptoms that are also are they also COVID-19 symptoms? Are we being told they're COVID-19 symptoms? Post-COVID-19 condition, brain fog and fatigue, right? Associated with, it's a sepsis symptom that's been associated with COVID-19. And even this thrombocytopenia here, this low blood counts, they have been COVID-19 associated with immune thrombocytopenia, a systemic review and meta-analysis. It has been associated with COVID-19 as well, right? So all these symptoms here, that the clinical features of sepsis are here basically the same as COVID, or unexplained, lack of blood clotting platelets if necessary actions are not taken, or if sepsis is not treated. Respiratory and renal failure, coagulation disorders. We have all kinds of problems with blood clots, right? And irremediable hypertension can develop. As summarized, sepsis is divided into progressive clinical phases, and MODS is its severest clinical symptom. Multiple organ dysfunction syndrome. I think that's something similar to what MODS is, right? Yeah. Sepsis is divided into progressive clinical phases, and MODS, multiple organ dysfunction syndrome, is its severest clinical symptom. Treatment. The success of the treatment in sepsis depends on early diagnosis. It hinges on the early diagnosis, right? That they weren't getting. At least a lot of people, because they were home under the centralized no treatment protocol. And then the treatment protocol was severely restricted once they did get into the hospital, right? The success of the treatment in sepsis depends on early diagnosis. Immediately starting the appropriate antibiotic treatment and supporting treatment and elimination of or recovery from the underlying disease. So you have the administration of antibiotics and recovery from underlying disease. Protection is the most important way of reducing morbidity and mortality rates. Protection. Most of the attacks are nosocomial. I think they get them in the hospital. They say they're getting them in the hospital. Sepsis treatments will be examined under two main headings: appropriate antimicrobial treatment and all-purpose support treatment. Each patient in the sepsis table should be definitely assessed in terms of resources, and if necessary, consultations should be taken in this respect. Antibiotics are mostly given empirically during the time until the determination of the active microorganism. Read that again. Antibiotics are mostly given empirically during the time until the determination of the active microorganism. So, whether it's viral or bacterial, you're getting the antibiotics. First line of defense. The first 6 hours are extremely important in terms of prognosis after the revelation of sepsis symptoms and findings. How's that play into the no treatment protocol? It is known that the shock incidence is reduced by half with the appropriate antibiotic treatment, no matter what the underlying disease is in sepsis developing from gram-negative bacteria. It is known that the shock incidence is reduced by half with the appropriate antibiotic treatment, no matter what the underlying disease is in sepsis that's developing from gram-negative bacteria. No matter what the underlying disease is. That's what I'm getting there. But either way, you get those antibiotics regardless of what the underlying disease is until they can figure it out, right? What are the symptoms? What are the symptoms of sepsis? Why is sepsis a leading cause of death? This is in 2024, after COVID, right? According to the Center for Disease Control, sepsis affects 1.7 million adults in the United States each year, and at least 350,000 of those adults die or end up in hospice care. It is the leading cause of death in hospitalized patients and contributes to 1 in every 3 deaths in the hospital. Did you know that sepsis deaths were that high? That's crazy. It's the leading cause of death in hospitalized patients and contributes to 1 in every 3 deaths. So, I mean, if you had people that were getting sepsis for one reason or another and they weren't being allowed to get treated, and it was the rate of it's already 1 in 3 of these hospitalized people are going to die, right? Is the leading cause of patients and contributes to 1 in every 3 deaths in the hospitals. Most cases of sepsis begin in the community. Most cases of sepsis begin in the community, but it can also arise from infections acquired in the hospitals. So most of these people are coming in. Was it 28% of the people coming into the hospitals that had COVID had sepsis, right? What causes sepsis? What causes sepsis? The immune system's job is to protect your body from infections. One way the immune system responds to infections is through inflammation. Right? Inflammation, which can produce symptoms like redness, heat, pain, swelling. But sometimes inflation doesn't cause any noticeable symptoms. Inflation doesn't cause any noticeable symptoms. In a typical infection, the inflammation eventually calms down as your body recovers. In sepsis, the body's inflammatory response to an infection spirals out of control. The inflammation can lead to blood clots, leaky blood vessels, and dangerously low blood pressure, which deprives the body's organs of oxygen. It deprives the body's organs of oxygen. It's sepsis. So if these patients have sepsis and they're trying to put more and more and more oxygen into the freaking lungs, and they think it's got something to do with COVID-19 and it's sepsis, I mean, what role does that play, right? If not treated quickly enough, sepsis can cause tissue damage, organ failure, and even death. Just throwing it out there for your consideration. I wasn't aware of any of this, but when I started reading this stuff, I found it very interesting as far as it goes and as it pertains to the COVID excess death numbers, to the COVID death numbers, the quote-unquote COVID deaths that are attributed to COVID, right? Sepsis, furthermore, inflammation is a necessary evil. Sepsis is one of the leading causes of deaths worldwide, and yet there are no therapies available other than ICU treatment. There are no therapies available other than ICU treatment for sepsis. The patient outcome is determined by complex interplay between the pro and anti-inflammatory responses of the body and a homeostatic balance between these two competing events to be achieved for patients' recovery. So you got this inflammatory response that you may or may not even be able to determine, because sepsis, the body's inflammatory response to an infection spirals out of control, just goes haywire, right? Is that something that they say happens with COVID? Attributing it to COVID when it's sepsis? Well, all these things, they began sepsis symptoms being attributed to COVID. What would that do? What would that lead to? Sepsis, why can it be so hard to spot? And this is from 2016 out of BBC News. Experts say that the crux of the problem is that sepsis can have a number of faces. But early on, all these symptoms can be mistaken for influenza or other infections. Without early treatment, sepsis can be fatal, and every hour can count. That's what they say, 6 or 7% increase of death every hour. Without early treatment, sepsis can be fatal, and every hour can count. And in some cases, there can be very few obvious symptoms at all until it's too late. That's my point. That's my point that I'm trying to show here. You know, you tested positive for COVID. So you have asymptomatic sepsis. All right? You got asymptomatic sepsis. But if you tested positive for COVID, you can't even get treated for it anyways. Can't get treated for anything. Except through a very specified centralized protocol. Acute respiratory distress syndrome, ARDS, and sepsis. How does this play into it? How does ARDS play into sepsis? And sepsis and ARDS play into the COVID protocol in COVID-attributed excess deaths, right? Sepsis, a syndrome in which the body's immune system overreacts to an infection, can have several life-threatening complications. One of those is acute respiratory distress syndrome, or ARDS. A lung complication involving inflammation and dysfunction of the endothelial layer. Sepsis-induced ARDS is deadlier than other forms of ARDS, making it a top priority for hospitals and researchers alike. Sepsis-induced ARDS is deadlier than other forms of ARDS. So it's even deadlier than other forms of sepsis. Deadlier than other forms of ARDS, making it a top priority for hospitals and researchers alike. This is from 2018. In relation to sepsis, ARD has a more rapid onset and a higher chance of resulting in mortality. In patients with severe sepsis, initial serum locate levels and microbiologically proven infections were both associated and increased occurrence of ARDS. And remember, sepsis increased the sensitivity for oxygen poisoning and oxygen toxicity with sepsis. Pathogenesis. ARDS is a heterogeneous syndrome, meaning it can be caused by several different pathways. The general pathway involves increased permeability of the endothelial cells of the pulmonary, capillary, and of the epithelial cells in the alveoli. Sepsis-induced ARDS is often caused by indirect injury to the lungs. However, pneumonia can directly injure the lungs, leading to ARDS, and can also cause sepsis. So if you've got pneumonia and you got diagnosed, you tested positive for, you didn't get diagnosed, you just tested positive for COVID, and you're mandatory no treatment under the no treatment protocol, and that pneumonia can lead to sepsis, right? Directly. Treatment. As of now, there is no simple treatment for ARDS. The treatment of sepsis-related ARDS does not differ from standard ARDS, where oxygenating tissue is the main goal. Again, we come full circle. Right? Acute respiratory distress syndrome, ARDS. I look to here. And on this, in the United States, about 190,000 Americans are diagnosed with ARDS each year. All ARDS patients must be given supplemental oxygen therapy, and most will be placed on a mechanical ventilator to help them breathe. Though there is no cure for ARDS, it's not uniformly fatal. With treatment, an estimated 60 to 75% of those who have ARDS will survive the disease. We know how to support people through ARDS very well, said Dr. whoever at Yale. Up here they're saying that 60 to 75% of those who have ARDS will survive the disease. But I got down here, according to the Cleveland Clinic, that half of all sepsis survivors will die within 5 years. Just putting it out there. I mean, what causes ARDS? Doctors divide the cause of lung injury that leads to ARDS. They divide the causes of lung injury that lead to ARDS. Direct lung injury and indirect lung injury. Okay? The conditions that cause direct lung injury include viral infections of the lungs, including by SARS-CoV-2, this coronavirus that causes COVID-19 infection. So, sepsis causes ARDS. Sepsis and COVID-19 have been correlated. This being together. Are they the same, just being diagnosed differently? But what one, I don't know. I'm just throwing it out there for your consideration. You know. So they have it that the viral infection of lung, including by SARS-CoV-2, is a condition that causes direct injury, direct lung injury. And the causes of lung injury that lead to ARDS are direct lung injuries, as well as indirect lung injuries that are caused by sepsis, the body's overreaction to an infection that can cause damage to multiple organs and systems, including the lungs. Drug overdose, right? Drug overdoses, same thing. Drug overdoses are high enough too. Out of these possible causes of lung injury, two of them, sepsis and pneumonia, make up 40 to 60% of all ARDS cases. Yeah. Out of these possible causes of lung injury, two of them, sepsis and pneumonia, make up 40 to 60% of all ARDS cases. What is the relationship between COVID-19 and ARDS? When the virus that causes COVID-19 enters the body, it frequently attaches to cells. That's just the freaking narrative here, right? It frequently attaches to cells in the upper airway. This sets off the immune response. It causes the inflammation, leading to the symptoms such as cough, sore throat, and fever, blah, blah, blah. In some cases, the virus, blah, 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 blah. When this occurs, COVID-19 can lead to ARDS, bottom line. Whatever the narrative is, they know they're saying COVID-19, they're admitting COVID-19 can lead to ARDS. Well, what's the pulmonary toxicity by oxygen in COVID-19? I wanted to get to this here too. So this is all a big circle here between ARDS, sepsis, and COVID. I'm just saying, somebody with more insight into these things, can look into it more, right? It's a reasonable cause to believe, to dive into it a little bit more here, to me, at least in my observation. Pulmonary toxicity by oxygen and COVID-19. Pulmonary toxicity by oxygen this is from 2022, has been known for over a century. Exposure to a fraction of inspired oxygen of 70% causes progressive pulmonary lesions and intensity of 70%. Usually bring in 21%, right? That's like 21% of the atmosphere, right? Yeah, exposure to a fraction of inspired oxygen, FiO2, of 0.7 or 70% causes progressive pulmonary lesions, and the intensity of the lesions is associated with the concentration and duration of hyperoxia. Lesions manifests just a few hours after the administration of oxygen in high concentrations, causing an increased alveolar capillary patency and a complex cellular response, including epithelial, endothelial, pro-inflammatory cells, and platelets that induce the destruction of alveolar capillary membranes with increased air spaces, vascular obstruction due to microthrombi, isn't that blood clots? In cellular infiltration that eventually leads to the loss of alveolar architecture, and in the long run to the pulmonary fibrosis. All oxygen-induced lesions are similar to those due to acute respiratory distress syndrome, ARDS. Also, in patients with established ARDS, hyperoxia can worsen clinical results. Finally, many of the pathological characteristics reported in hyperoxia occur also in ARDS due to COVID-19, since it has been reported that in these patients, lungs increased air spaces following the destruction of alveolar septa, alveolar swelling, capillary thrombosis, perivascular infiltrates, and fibrosis have been found. A lot of big words in there. Basically saying the lung damage is there from oxygen. Right? Yeah. Causes progressive pulmonary lesions. They're similar to ARDS. That they've attributed to COVID. The appearance of COVID-19 has challenged respiratory support, and the need for applying elevated fractions of inspired oxygen has been a constant in many patients, whether through high-flow nasal oxygen therapy or concomitantly to ventilation systems. However, the high mortality rates reported in the cases of ARDS, an average of 39%. What would they say mortality of sepsis was? Half of all sepsis survivors will die within 5 years, right? However, the mortality rates reported in the case of ARDS, an average of 39%, is indicative that, at least in some cases, the application of elevated concentrations of oxygen is worsening or triggering COVID-19 related ARDS-like lesions. It could even cause a vicious circle that would create the need to increase the concentrations of oxygen gradually in the air breathed, and thus causing greater pulmonary impairment. And the vicious cycle begins, right? This possibility, together with data obtained by other authors, that most patients with moderate to severe acute respiratory failure due to COVID-19 and even cases with radiological findings and comparable gas exchange with ARDS recovered with CPAP and inspired oxygen between 40 and 60 should, in own opinion, make us reconsider or detail the current strategy of respiratory support. Make us reconsider the strategy of respiratory support. And that's this study right here. It's right there. Now, the other thing that I wanted to touch on really quick towards this is that this whole, I heard a scene where Kevin McCarran has thrown, kind of laughed off, the idea or the hypothesis that the possibility of oxygen poisoning, oxygen toxicity being a possibility in the whole COVID, excess death count, right? That the possibility of the whole protocol murdering people through oxygen toxicity, or as I'm showing here, through a lack of treatment due to sepsis, and the whole vicious circle of the centralized non-treatment protocol. It all comes into account here. But he kind of laughed the whole thing off because he said because in Brazil they ran out of oxygen and they still had people dying from COVID. So I wanted to just kind of dive into the whole Brazil thing here a little bit and see if Brazil's allegedly running out of oxygen had nullifies the possibility of the oxygen toxicity attributing to COVID deaths and excess deaths, Coronavirus undocumented explosion spreads around Brazil. This is from 2020. Figures in Brazil's civil registry show that there was a near 10% rise in the number of people dying of acute respiratory syndrome in March compared to last year, which underscores accusations that Brazil is underreporting, they're saying here. But it just could be the population pyramid, because the population pyramid into the number of attributed COVID deaths also comes into play here, right? Coronavirus cases were growing globally, but Brazil continued with its plans. It registered its first case in February. Some scientists are modeling estimates to get an idea of the real number of cases, according to one group of Brazilian researchers, 15 times the official number. So they're trying to say that these numbers, near 10% rise in the number of people dying, could have easily just have been attributed to the population pyramid of over 65, the people that were reaching life expectancy, and the increased number of people from the baby boomer bump type thing coming up into the population percentage of the population is over 65 was increasing extramentally, right? 10% rise in those numbers could easily be attributed to just that alone. And I just kind of threw that in there because there's all kinds of numbers are coming out of Brazil are corrupt in a number of different areas is what I was kind of showing here. A reduction in life expectancy in Brazil, assuming that the death rates would have been equal to 2019, but they weren't because you got more people of the dying age naturally people that are reaching life expectancy naturally that are dying. So excess deaths from all cause. Again, moreover, most COVID-19 deaths occurred among the elderly. Right. The estimates presented in this study indicated 13.6% excess death mortality from all cause in Brazil in 2020. 13.7, 13.6 was easily within the increase, or approximate to the increase in population over 65. And I did that show. If you haven't seen the show that I did that was my last show actually, on the population pyramid, baby boom bump, how that and compared to the excess deaths versus the excess deaths. Yeah, 13.7% here, 13.6% here, right? But I just put on here the baby boom bump data. Side note on all that is that in 2022, the total number of persons aged 65 years or over in Brazil reached 10.9% of the population, rising 57.4% of the, it rose 57.4%. So why wouldn't they have an increase in death rates, right? And I had more information on that a little bit. But I got into the oxygen shortage in Brazil. Brazil is suffocating. COVID surge creates surge in COVID crisis. This is this article out of 2021. Read some of this. Just get an idea what's out there, right? There are fears that a lack of oxygen supplies seen in Manaus and the Amazonas state capital could be found elsewhere. They had this, so they did have a shortage of oxygen. According to a statement from the hospital, the deaths, Brazil is approaching 300,000 COVID deaths, and it's set another weekly record last week with 2,255 deaths and 408 new cases of COVID, according to Johns Hopkins. According to a statement from the hospital, the deaths were due to a failure in the oxygen distribution system rather than a lack of oxygen. So they had the oxygen, but everything's state-run down there. They've got their state-run healthcare system. They got their state-run producers that produce the oxygen. Everything's state-run, and they've been appealing to the private sector for help. So the cries for more and more of a state healthcare system, state-run healthcare system, universal healthcare system is kind of basically that's what they're saying here. It's not an actual shortage of oxygen. It was a shortage in oxygen distribution system. The system rather than the actual lack of oxygen. However, the health secretary of the hospital informed Al Jazeera, that the problem had occurred due to overflowing COVID intensive care units, which are currently operating at 300% above average. I wonder how many of them were undiagnosed sepsis or undiagnosed pneumonia, which could lead to sepsis and ARDS, right? And that they had to give oxygen, that they did give those that they did give the oxygen to. The higher mortality rates with the sepsis, all that comes into play, right? Oxygen shortage risk across Brazil. They're saying that the country's only homegrown firm that makes this oxygen also blames the federal government's delay of handling the pandemic for the catastrophe. They're seeking help from the private sector. To the north, Amazonas State Health Secretary is dismissive of the risk of oxygen shortages, informing Al Jazeera that the state had reached an equilibrium of oxygen supply demand since its healthcare collapse in January. So, the narratives are out there. and they showed people with, they showed garages and welding shops bringing their oxygen tanks in and stuff. But that doesn't say that they actually ran out of oxygen, that they still weren't giving people oxygen, or that oxygen toxicity isn't a thing. As we went down through, there's a lot that comes into play, and it all bounces off that no treatment protocol too as well, right? That centralized no treatment protocol. Anyway, sepsis was, when I saw that sepsis got brought into the conversation on one of those studies, I had to dig into it a little bit deeper. And it's information for your consideration. I'm not saying that there's any particular nefariety that's happening out there, but boy, does it raise a lot of questions, right? And I'm just throwing out this information that I kind of dug into out there for your consideration to roll into the conversation, because we sure shit ain't getting any of this. None of this has been considered from the medical freedom movement, at least that I have seen. I mean, how many people on the medical freedom movement, on all these Malone's minions at all these COVID summits that they're having all over the world, how many times has sepsis been brought up? If it has been brought up, it hasn't been a mainstay. It hasn't been brought to the forefront. Just sitting on the narrative. Medical freedom movement just sitting on the narratives of there was a novel virus, Therefore, the need for vaccines. If there was a novel virus, the only thing they're fighting back against is these frickin' vaccines, or certain aspects of the vaccines. But then again, now we have Kennedy in there, right? And but he supports the vaccines, and he supports the child schedules. So we'll see where that's going to go, right? Hope you got something out of it. I'm Joe Marshall. Thanks for stopping by, and I look forward to the next one.